everybody. This is Priya Gupta, and I'm here with Dr. Paul Singh and Dr. Nate Radcliffe. And today we are going to be talking about adopting modern drug delivery platforms. There's the usual set of drops that you get taught when you're a resident. Okay, we need a steroid, we need an NSAID, we need an antibiotic. And over the last decade, there's been so much change and shift in terms of not only medications that we use perioperatively, but also, in other settings in our clinics. And we thought it'd be a great opportunity to chat about maybe why each of us has dived into looking at modern platforms for drug delivery and, how it's made an impact in our practice. So welcome, guys.
Thank you. Good to be here.
Great to be here.
So I think that, the easiest first place to start is, just with drops in a bottle. Like, this is an intimate part of ophthalmology, right? You can't get out of ophthalmology without thinking eye drops. And the first platform or drop that comes to my mind is actually a modification of steroid molecules, actually. So in the last few years, one that I've incorporated into my own practice is actually Inveltis, which is a lotoprednol etabonate molecule with what they call mucus penetrating particles. And, when I first heard about it, I wasn't totally sure what mucus penetrating particles were. And I wasn't sure about why I should care about it. And as I've dived a little bit deeper into it, and thought about, well, sure, we put a drop on the eye, but how do we actually get that drop into where we want it to be? So, how have you guys, is it something that you guys are using? How have you guys approached some of these modern formulations of eye drops?
You made a good point. For me personally, I want to control every variable around surgery in general, right? And we're so thinking about how anal retentive we are, our diagnostic tools, our measurements, et cetera. Then intraoperatively, we're like, oh my God, I'm 2 degrees off my toric lens. And then postoperatively, like, yeah, whatever, take a drop you want. And we know in the glaucoma world, in my specialty, right, we know that the inactive ingredients, the vehicles, have a huge part and they play a huge role in the efficacy, the bioavailability, the dosing regimen. And so to your point, whether it's Inveltis, I use Lotamax and Inveltis both, I think both of them have vehicles that have allowed us to have better absorption, whether it's mucopenetrating, mucoadhesive, depending on what they use, but also the ability to actually decrease the dosing regimen for twice a day for Inveltis or 3 times a day for Lotamax. I think it does help patient satisfaction and compliance. And I'm a big fan of educating patients on the difference between a brand name and generic. Whatever brand name you use, I want consistency in the inactive ingredient because, you think about a suspension. If you're not shaking that bottle, you're not getting much of that the first couple of weeks. And of course, when you don't really need it, all of a sudden, bam, at 3 or 4 weeks, you got it. And so for me, I'm a big fan of not having a taper dosing. If I use Inveltis or Lotamax, it's just the idea until it's done, so to speak, versus having a taper 4, 3, 2, 1. And so because of all the benefits of the new vehicles and these newer formulations, from a safety, I think from a compliance and a satisfaction, and then the consistency, so I know exactly what they're getting, and I know that I'm not going to worry about it's a generic issue or not. Those are reasons why I've kind of adopted those new technologies.
Yeah, Paul, I agree with that. And, I think in glaucoma, one of the things that we've learned a lot about over the years is that reformulating can really have big impacts on allergy rate, tolerability, and efficacy. And I think that, allowing more molecule to get past the mucus layer and then into the eye is another part of that story, because you just get more out of the drug and you can use lower doses and sort of be smarter about how these drops are delivered. So I think, we can often, today with a lot of generic pressures, it's easy to be cynical and say, oh, this steroid's a steroid. But we just know that the eye was put on this planet not to absorb things on its surface. It gets irritated when things get on the surface. And you have to be really careful about what you're putting on the surface of the eye, especially in that perioperative period when you want those eyes to look good and not be irritated to have the best visual function. So I think we do well to pay attention to the formulations we're using, and it's usually going to mean brand named products.
I think that one of the reasons why a lot of docs shy away from maybe even, taking the step to learn about these modern drug delivery platforms, it is just sometimes there's a barrier to implementation in our practice. And when I first started using Inveltis, one of the things that I did was I actually switched to a specialty pharmacy. And that was just like this revolutionary thing for my office, because we were just getting hammered with prior authorizations, and, just not what clinic has extra staff, right? No one has extra staff members to help with, sitting on the phone with insurance. And so the specialty pharmacy actually really just like absorbed all of the garbage, is what I would like to describe it as, if, and they'd have a standing substitution list. So, if the coupons don't work, if the insurance won't cover it, what else can the patient get? And then it saved our office so many phone calls. And honestly, I mean, I feel like for me, it was important because I do, Paul, just as you say, care about what goes on the eye. I care about addressing inflammation quickly. And, we have options for drugs that have BID dosing. I can barely take a multivitamin at bedtime every night. How do you expect a patient to take an eye drop 4 times a day? And so I feel like, if they're only going to use it twice, I want them to use something that's going to penetrate into the eye. So that made a huge difference in our practice. Is there anything else that you guys are doing to help kind of with the burden of sometimes that comes with branded drops?
What I do, and I learned this from my colleague Mitch Jackson. And basically, I actually have them find a little a checkbox that says that they do not want to use the drops that I recommend. They're accepting that, they realize that these are not what I recommend. If they want to, let's say, do generic, it's not to make them feel bad or tell them that they're wrong. It's just to say, look, I recommend this. I'm trying to control everything I can, and you're saying you don't want to do that. That's fine. Just letting you know ahead of time. But I also gave this is something I share with all my glaucoma or cataract surgery drops, a non-branded form that talks about the objective differences between a brand name and generic. The fact that multiple companies make a generic, a pharmacy may outsource a different company each time you get it, et cetera, and I don't have control over that. And so just give this form to explain why, personally, I think it's so important, whether we're talking about premium lenses, a femtosecond laser, or a more expensive drop, hypothetically, giving them the value add. Why is this important in a very concise, quick way, because all of us don't have a lot of time. And that's helped, again, just to make them understand, educate them on the importance of why we want to do what we want to do.
Paul, there are you're describing basically some tools and tricks that you use to get patients on the medications that you prefer. And, this is part of the skill set, and it's not always the skill set you'd think you'd need. You need to learn about the medicines and learn about what's available. But so one of the things I've learned a lot about are insurance companies and, what plans are covering what. And I think the specialty pharmacy is a tool that helps you achieve a clinical goal, and it's a critical one. I couldn't practice today, and I didn't even use them a few years ago, but it allows me to prescribe more medicines that I need. And as we get and start talking about, which I hope we do, sustained steroids that we can give with cataract surgery, understanding the insurance landscape there, is very important because it helps us achieve those outcomes.
You're actually right. And you mentioned that earlier about the third-party pharmacies or independent pharmacies. I think it's true because, a lot of these Walgreens, other type of pharmacies just don't accept the cards, or they accept it, they don't run it, and they get kind of complacent with it. And so you're right. If you have a specialty pharmacy, all these drug companies, Veltis and Lotomax, they have coupons that work even in Medicare patients for cataract surgery. And so when you hear, oh, it's not covered, it doesn't work, it's because the pharmacy just chose not to run it, really. So that's a good point.
Or your patient dropped it out of their folder from the time they left your office.
That too.
That has happened several times. So, moving out of the office and into the operating room, because, I think cataract surgery is probably the most common surgery that most offices are doing. And there's been a number of advances in the OR for drug delivery. The two that come to my mind are Dexycu, which is from EyePoint, and Dextenza from Ocular Therapeutics. And those are, basically, excuse me, steroid that can get delivered to the eye without the patient taking an eye drop. So tell me a little bit about your experience so far with either of those products. Nate, you want to start?
Yeah, sure. So, I know Paul's going to mirror this experience, but, he and I both do a lot of combined cataract and glaucoma surgery. And, one of the things I'm happy to report is that you can use both Dextenza and Dexycu in your glaucoma patients. And you can use them on glaucoma surgeries without cataract surgery, and you can use them on patients undergoing cataract MIGS. I'll speak a little bit about my Dexycu experience because, that's been an interesting adventure. Dexycu is a medication that this spherule of dexamethasone, ideally placed in the sulcus of the eye after the cataract surgery. That can be challenging. So it's a surgical technique, but it's also a medication you're using. I pick patients who have Medicare and a good secondary insurance because I find that that's where it really works well, and you can get samples as well. So there's a lot of communication with your operating room. And then, there's some tricks for DexEQ. If you have trouble keeping it in the sulcus, you can put it in the capsular bag, just sort of off to the side of your IOL. And I even will deliver it using a 30 gauge needle into the vitreous cavity through a pars plana approach. And believe it or not, that works really well because you can deliver a high volume of DexEQ. That's off label. You can deliver a high volume of the steroid, but you can get excellent anti-inflammatory control because you've got more space to play with. And as opposed to something like Trimoxy that I've used in the past, that creates a lot of positive pressure because you're putting in a huge amount of volume in the vitreous. A little bit of DexEQ goes a long way, and so you can give a good amount of DexEQ in the vitreous without putting any positive pressure at the end of a case. It could be the end of an Ahmed valve or a phaco. And you also have fewer floaters than with Trimoxy. So that's been a great evolution, and it just shows you that you get these products and then you have to learn how to make them work with your surgical techniques.
That's cool, Nate. I mean, let me ask you, are you changing your volume or dosing when you do intravitreal versus in, let's say, the sulcus or in the bag?
I do, and I tend to give a little bit more volume of the DexEQ when I'm going into the vitreous. There's more room for it. I've been following these patients very carefully. This has been done thousands of times. We don't have publications on the safety, but I think the safety is there. You can give a little bit more volume, and so you can get some good anti-inflammatory control, presumably also for the macula, because you're now delivering drug into that cavity. So excited to see how that plays along with CME.
Yeah, you made a good point. I mean, how I differentiate, I use both Dextenza and DexEQ, and how I differentiate, they're both very valuable tools to decrease the need for topical drops post-surgery. But then Nate mentioned, if you have someone who's diabetic, ERM, had history of uveitis, all those different scenarios, I definitely tend to use DexEQ for those patients. Whether it's, I haven't done intravitreal yet, but that's a good idea. But I use it in the intracapsular bag technique because I think with the IOL kind of keeps it's hydrophobic and lets it stick there so it doesn't come and float into the anterior chamber. So there is a little technique, a little bit of getting used to it, but it's safe. Patients do like it a lot in terms of the very little in terms of outcomes of patient dissatisfaction. Even if it goes into the anterior chamber and sinks, it doesn't really hurt the eye. They do very well. But I use Dextenza a lot too. I think the benefit of Dextenza for me is having it in the intracanalicular system, also in the punctum. It allows us to decrease the outflow of aqueous, so you have more tears on the surface. So if someone has an ocular surface disease, I really like that idea. You can use it in lower and upper punctum. So I've used it in both a punctum to allow us to decrease the need for even steroid drops after, let's say, a subcon surgery like a Zen. So I can titrate one or both canalicular systems. And I think that patients love it. In fact, we did a study that looked at the efficiency and time, both from a glaucoma perspective for MIGS and for steroids. You decrease one postoperative drop, you improve your efficiency and flow for your patients in terms of your tech time by 5 minutes. So we had the techs look at callbacks from the pharmacies, from the patients, post-op kind of engagement with the patient, making sure you verify what drops they're on. 5 minutes per post-op visit we were able to save, including the callbacks, et cetera. So it's a huge advantage for the patient, of course, for us not having to worry about control if they're taking it or not, and then the staff and the efficiency as well. So I think drug delivery from a steroid use, I think, is huge for us.
That's amazing. I mean, 5 minutes a patient. I mean, on a 20, 25, 30 patient
A lot
day.
of time.
I mean, that is a lot of staff time, which is quite amazing. And similar to you guys, so on our formulary, we have Dextenza, and it's something that I've been using more and more recently. And in the beginning, I had a little bit of like okay, who am I going to use it on? Should I use it on everybody? And one thing that was really helpful in our office is they started putting little stickers on the chart of which patients had, Medicare that would cover it. And it made it a little more seamless for us to know about the coverage issues. And it didn't take a lot of pre-time. In terms of like patient experience, Paul, I can't agree with you more. I mean, for the patients to be on maybe 1 or 2 drops. I use intracameral antibiotic as well. That that is huge compared to using 3 eye drops. Intraoperatively, it's funny how we think of putting a punctal plug in, not a big deal. I think there's a little bit of a learning curve, nothing too crazy, but one thing that I've started doing is putting a little bit of viscoelastic in the puncta after I dilate it. And that has really like facilitated kind of the smooth delivery of the steroid insert into the puncta. And it used to be something that I was kind of like, do I have to put this in? And now it's just straightforward, easy. And the patients thank you for it. Patients don't, we take for granted using eye drops. It's part of our day, 1,000 times a day, and we're immune to thinking that it's a huge problem. But a lot of patients fear eye drops. Even just this past week, I had a woman tell me, okay, so you promise me that I'm going to be okay with using eye drops. She wasn't afraid of the surgery. She was afraid of the eye drops post-op. So, I think that it's a little daunting to think about changing our, pattern of post-op drops and substituting an advanced technology insert or medication that we're delivering into the eye. But I think it's something that I would challenge everybody out there to try. Wouldn't you guys say the same?
Absolutely. I mean, the risk ratio is so low, considering the dexamethasone is a very safe medication, but even externally, like Dextenza, what's the worst that happens? Take it out. Just flush it down the system and it's gone, and it dissolves on its own in 3 or 4 weeks. So I feel like the safety's there. And you can always supplement if there is a need. And to your point, Brie, I think that it's really straightforward to insert into the intracanalicular system. There are some nuances. You want to stretch the lid temporally, and you want to have the right angle, etc. But I find that it's pretty straightforward. Even the small punctum, don't be fooled, everybody out there. If you have a small punctum, it doesn't mean the canalicular system is narrow. Just dilate that punctum and it's a big, beautiful open canalicular. So I agree with you. I think it's worth a try.
Yeah, I'll echo those comments and just say that I recently had a big milestone in my practice, which was a full busy operating room day where I was able to use all the different tools to get all my patients some sustained anti-inflammatory therapy, every case. And it took a lot of different tools, all the tools at my disposal, Dexecute, Dextenza, a little Trimoxy, but it really moved me in the direction that I've been wanting to go for a long time, which is to just know that those surgical outcomes are basically guaranteed now.
Absolutely.
I'm not leaving it to chance with patient compliance. It's not to say I didn't use any post-operative anti-inflammatory therapy or that I wouldn't supplement some patients, but at least everyone has a foundation and a safety net now. And I think that's, it took some work, and that's what this is all about. Here we're trying to identify the barriers to us moving forward and adopting new technology and overcome them by sharing our experiences. And, I hope that we can all continue moving in this direction.
One thing I want to add real quick for Dextenza, now there's actually the CPT code, which is they have a specific code that actually now in our area in Wisconsin with NGS is getting paid. So again, it's not the reason to do it, of course, but for your efforts, you are getting paid now for a lot of these areas, a lot of these MACs. So something to think about too when you're starting to implant these as well. And I think lastly, for us, it's so rare for a glaucoma specialist to actually make people happy. But if as a cataract surgery and to take them off of medications, not only from the glaucoma side of it, but also the steroid side, these patients are happy. In fact, in our studies, we took patients who were happy at 90 days. We asked them at one point in time post-operatively, did you really expect to be happy and expect the outcomes? And it was an average of about 1 week. So, if you're someone who's had dry eye, on all these different drops, at 1 week, they're still feeling miserable because their vision's fluctuating from the surface. They're not going to be happy and not refer patients to you. So it's really helped a great deal getting them off some of those steroid drops topically and being able to help decrease the chance of their ocular surface being an issue.
When both of you are, as glaucoma specialists also, let's not forget about Durista also. Interestingly, I've actually used it like in the perioperative setting, trying to help patients, temporarily get off their PGAs. Have you guys been doing this at the time of cataract surgery at all? Just curious.
Nate, go ahead. Have you tried it? I haven't done it yet at the time of cataract, although you could, from an insurance perspective, it might not be covered. It's bundled. So I have done it actually at the time of a MIGS procedure. So let's say you're doing a canal-based kind of standalone procedure, you can insert this at the end and it will be covered for you. Unfortunately, with the time of cataract, because it's bundled, it would be more difficult from a cost perspective. But to your point, I think getting the ocular surface healthy, whether it's a subcon surgery like a Zen or some other subcon surgery, or even just worrying about biometry and looking at your, toric marking, et cetera, I think you really got to get that surface healthier. So for us, for me at least, getting them off that PGA using Durista, and sometimes I've been surprised. I've been able to get off of people not just their one PGA, but sometimes 2 or even 3 meds, depending on compliance, and being able to get that surface healthier going into surgery, whether it's toric lenses or subcon surgery, has really been a huge benefit. So I've used it around surgery for that rationale.
Yeah, Paul, I do have a number of patients where I've given the Durista and we're anticipating a cataract surgery, and we've got them off their topical agents, and we're just letting the eye cool down, repeat the biometry, and then to the operating room where we may continue a plan of Durista in the future or see what we can do with MIGS with the cataract. But again, tools, right? These are just different ways of achieving good surgical outcomes, making patients happy, and Durista is a critical tool for a lot of other patients as well, including patients on medications who aren't tolerating them. We know about all the side effects of our topical agents, but it can have a role in cataract surgery planning as well. So, it's pretty exciting technology.
Amazing, you guys. Well, for everyone out there, we hope that you try something new, whether it's advanced drug delivery platform in an eye drop or at the time of surgical a procedure, whether it's in the eye or in the puncta. But as you can see from all three of us, it's made a meaningful difference to our patients and to our practice. And we encourage you to get out there and try something new. Thanks, Paul. Thanks, Nate. And
Thanks, guys.
have a great one.
Thank you.
Take care.